Thank you for joining us today. My name is Gary Kaufman, and I serve as the Medical Director of Sinai Health System's Program for the Deaf and Hard of Hearing Community. Today, we will give 3 scenarios involving deaf patients and hearing doctors and see what happens when communication is not provided. All of these things are true. All of them can be prevented with a certified sign language interpreter. Thank you for joining us. The first scenario occurred in the outpatient setting. A 54-year-old deaf male was working with his physician for many years and actually liked his physician. The problem was the patient did not have communication access. This forced the patient and the doctor to write notes back and forth during the entire encounter. After several years, the patient got very frustrated with this process and moved to a new physician who provided an interpreter. Upon the initial vitals with the new physician, the patient's blood pressure was found to be elevated. The doctor asked him about this and said, "Have you ever had high blood pressure before?" The patient denied this, saying, "Nobody's ever told me I had high blood pressure." Well, sure enough, a couple weeks later, when the old chart arrived, the patient not only had a diagnosis of high blood pressure, but also was given medication. After discussion with the patient, they realized what happened. The patient was given a piece of paper with the word hypertension on it. The patient didn't understand this word and thought he was sick, took the medicine, and thought he was cured. This scenario led the patient to a risk of heart disease, of stroke, and of kidney disease from untreated hypertension. This would have been solved with communication access. The second scenario occurred in the inpatient setting. A 37-year-old deaf male was admitted with a presumptive diagnosis of chest pain. The first patient to take the history was a medical student. The medical student didn't think to bring an interpreter and communicated with the patient, writing notes back and forth. The medical student decided the patient had cardiac chest pain and reported this to his resident. When the resident came, he validated the information, again using pen and paper. This information was then relayed to the cardiac fellow and the cardiology attending. The cardiology attending with this information scheduled a coronary angiogram in the morning. In the meantime, the internal medicine attending came and interviewed the patient, but this time with an interpreter. They retook the history carefully and recognized that the day before, the patient was working under his car with a ratchet for about an hour. The diagnosis was later found out to be costochondritis, non-cardiac chest pain, and the patient was sent home with nothing more than an aspirin. Had the internal medicine attending not brought in an interpreter and provided communication access, this patient would have been subjected to a coronary angiogram with all its associated risks, complications, morbidities, and possibly mortality, all needlessly. Again, it's important to have communication access with deaf patients. The third scenario involves a 76-year-old deaf woman who was admitted to the hospital for a surgical procedure. The patient was admitted overnight for IV hydration. That same evening, a medical student who spoke some sign language went to the patient's bedside as a social visit. He asked her, "Why are you here?" The patient clearly didn't know. The medical student said, "1 second, I'll go to the nurse and find out." The nurse told the medical student, "Well, the patient has been consented for a below-knee amputation in the morning." The medical student replied, "The patient has no idea. She doesn't know what's going on." The nurse, therefore, appropriately called a sign language interpreter and called the doctor back to reconsent the patient. This time, with both the doctor and the interpreter, the patient understood what was going to happen, the risks and the complications of the procedure. Imagine yourself the following morning without communication access, waking up and having your leg missing and not knowing why. This should never happen. As physicians, we are bound not only by ethics but by law to ensure if effective communication, and informed consent. We can do better. Now, I will introduce 5 syndromes that are common in deafness with other associations that we as doctors need to look out for. The first syndrome is Pendred syndrome. Pendred is autosomal recessive, and the gene codes for a protein pendrin. Pendrin is a multifunctional ion exchanger. In the ear, it serves to cause problems with the endolymphatic fluid. In the thyroid, it causes problems iodinating the thyroid hormone. Patients present with deafness and goiter. Usher syndrome is a very common autosomal recessive gene that codes for the retinal epithelium and codes for products in the cochlea. These patients present with deafness and progressive blindness. This starts with night vision problems and progressive tunnel vision. As a provider, it's very important that we identify and link these patients with care early on. These deaf patients need to be connected to providers who can teach them Braille, tactile sign language, and how to walk with a cane prior to them becoming blind. Waardenburg syndrome is an autosomal dominant mutation affecting the melanocytes and the facial bone formation in the body. Patients present with deafness, heterochromia of the irises, and often a white forelock. Alport syndrome is most commonly X-linked, but also autosomal dominant and autosomal recessive genetic mutation. It codes for the alpha-3 and alpha-4 type 4 collagen chains. When this is mutated, problems occur in the endolymphatic fluid, and problems also occur in the glomerular basement membrane. This creates the phenotypes of deafness with glomerulonephritis. The final syndrome, and probably the most concerning, is Dravet-Lang-Nielsen syndrome. Its gene product codes for a potassium channel in the ear and in the heart. Patients who are often deaf or hard of hearing may present with syncope. What's happening during this syncope is patients are exhibiting episodes of ventricular tachycardia, which can, in some cases, degenerate into torsade de poids, ventricular fibrillation, and full cardiac arrest. It is very, very important that as providers, when our deaf patients come in with syncope, we evaluate the patients for Dravet-Lang-Nielsen syndrome, lung QT. If needed, an AICD, automated internal cardiac defibrillator, can be placed in the patient to save their life.